This is the recording for the radiographic positioning and anatomy 2 for the lumbar spine. So just a reminder, we've been working our way through the spinal column, starting with the cervical, moving into the thoracic, and now we are on the lumbar, and then we will follow up with the sacrum and coccyx next week. So as a reminder, the curvature of each section of the spine includes the cervical spine with a convex or a lordotic curve. The thoracic spine has a concaved or kyphotic curvature. Now the lumbar spine has a convex or lordotic curvature, and the pelvic area with the sacrum and coccyx has the concaved or kyphotic curvature. Moving into the individual anatomy of the lumbar vertebrae, there are 5 on an average adult. It occupies the posterior region of the abdomen, and the special features that a lumbar vertebrae has, their transverse processors are smaller than that of the T-spine, primarily because they do not articulate with the ribs. Then they have the pars or interarticularis, which is part of the lamina between the articular processes, the superior and the inferior processes. Now looking at these individual vertebrae, we can see the inferior vertebral notch, in which forms the intervertebral foramen. Of course, just like all vertebrae, there's the body, the spinous process, and the transverse process. We also take note of the superior articular process as well as the inferior articular process. The pedicle is what projects posteriorly from the vertebral body, which you can see here from the superior view of the vertebral body with the pedicle that projects posteriorly, then followed with the transverse process, then the superior articular process with its facet that articulates with the inferior articular process of the vertebrae that sits superior. We also have the lamina, and in between the articular processes we have the pars are interarticularis. The spinous process projects posteriorly. The angulation difference between the joint spaces that we will view for the spinal column of the zygapophyseal joints range between the 30 to 50 degree rotation. 45 is our average rotation, and then for the full 90 to a lateral view is where we will see the intervertebral foramen. The anatomy, as seen on a radiograph of the vertebrae, includes the spinous process, the pars interarticularis, the pedicle, the vertebral foramen, the body of the vertebrae, and the transverse process. Now from the side view, we have the body, the inferior vertebral notch, where we're going to see the intervertebral foramen, the pedicle, the superior articular process, the inferior articular process, and the spinous process. Then again, we need to note yet again regarding when we see the zygapophyseal joints. They are on average at a 30 to 60 degree angulation from the midline of the vertebrae. On average, we're going to rotate our patient 45 degrees to see the typical zygapophyseal joint. Per the ART, we will cover the following positions or projections: the AP-PA, the lateral, the L5-S1 spot shot, the posterior and anterior obliques, the AP axial L5-S1 interspace, AP side bending, and the lateral flexion and extension. Starting off with the AP L-spine, this will be completed on a 14 by 17 cassette that's lengthwise, with the patient either supine or standing. Or you can also complete this procedure as a PA in order to reduce the radiation exposure to the ovaries or gonads. The SID is at 40 inches with a 40 kVp using the center cell, ensuring that the spine is superimposed over the AEC. Your central ray will be perpendicular to the image receptor at the level of the iliac crest. Suspend the respiration on expiration. We have to ensure that we get the diaphragms above the level of the lumbar. Otherwise, it will cause overexposure of the vertebrae. The patient is again supine or upright, but if our patient is supine, ensure that the mid-sagittal plane is centered to the midline. The arms are across above their chest and out of the way. And to reduce the lordosis, we are going to flex the hips and knees and place a sponge underneath their knees, and this will reduce the lordotic curve of the spine. The anatomy that we will see on a radiograph includes the entire lumbar, as well as the lower portion of the T-spine, generally T12. Collimate to include the psoas muscles. Ensure that there are no artifacts from clothing. That includes a waistband, the elastic waistband of pants. X-ray penetration through the vertebral structures. Open intervertebral disc spaces. The SI joints are equal distance from the spine. And we see symmetry of our spinous processes as they run down the middle of the vertebral bodies. Now, just to note the reason for the leg position. As you can note here, with the correct position of the hips and knees flexed, we see that reduced lordotic curvature to the table. Similar to when you were positioning for the wrist. Last quarter, we flexed the fingers in order to reduce the curvature of the carpal tunnel. So here we're going to see a large amount of lordosis, whereas if we flex our hips and knees, we're going to reduce that curvature. And on a radiograph, we can see what that looks like. So with the legs not flexed, you can actually see kind of an outline of the vertebral bodies, and when they are superimposed into the disc spaces. Now, if you were to flex the knees, you're going to see these complete open disc spaces and only one outline of the vertebral bodies. Now, collimation is also important for the lumbar. While some facilities may keep the collimation open in order to identify incidental findings within the abdomen, but in order to have an optimal contrast of your anatomy, collimation is necessary. And we're going to collimate to approximately a 7/17, similar to that of our T-spine. And we can see a better radiographic density and exposure throughout the spine, whereas if we're looking at a fully open view here, we have a lot of scatter, and which causes it looks like this is actually overexposed. So we actually have a high contrast between the scatter radiation area and the actual spine, making it look like it's underpenetrated. Now for the lateral spine, the patient will be lying on their side, whether they're right or their left, preferably the left side to reduce the magnification of the heart. But in this case, the lumbar spine is low enough that the heart is not going to be superimposed. However, the patient can also be standing, and this is when you will be visualizing the intervertebral foramina, 14/17 lengthwise cassette with a 90 kVp at the center cell, 40-inch SID, centering perpendicular to the image receptor, approximately down the mid-coronal plane at the level of the iliac crest, suspending on full expiration so that the diaphragms are not superimposed over L1. Correct position for the true lateral is similar to that of the lateral T-spine, where you're going to flex the knees and arms, as well as placing a radiolucent pad underneath the back. Now, if we have a continued curvature of the spine, even though we're trying to put a sponge underneath them, but there you note that there is a curve. You can then use a 5-degree caudal angle in order to project through the joint spaces. But by placing a sponge underneath the curvature of the waist, that should lift the spine parallel to the table. Ensure that there is no rotation on your radiograph. You're going to have all of the margins of the vertebral body superimposed, as we can see here. Should have one outline of that bony cortex. And you're going to be nearly superimposed iliac crest. Here's the iliac crest on one side and here's the other. The spinous processes will be seen in profile and the vertebrae should be in the middle of the collimated field. Now moving on to the L5S1 lumbosacral joint, which we call the spot shot. This is completed on an 8x10 cassette lengthwise. With a 95 kVp at center cell with 40-inch SID. Centering when the spine is truly horizontal to the image receptor, you're going to be centered perpendicular to the mid-coronal plane to a coronal plane that's 2 inches posterior to the elevated ASIS and 1.5 inches inferior to the iliac crest. If you're not able to have a horizontal plane to your spine, to your image receptor, you will use an angle of 5-degree caudal for males and 9-degree caudal for females. However, by placing that sponge underneath the waist, we should be able to elevate the spine to be parallel to your image receptor. Suspended on respiration is suspended. Placing your patient to ensure that the mid-coronal plane is perpendicular to your image receptor. Hips are flexed, knees are bent and slightly flexed as well to ensure that the hip joints are perpendicular to your image receptor or to the table. And ensuring that the arms are up out of the way as well. On your radiograph, you'll be able to identify the inner space of L5S1. You may also see most of L4 as well as most of the sacrum in the center of your image. Now for the APO-BLIKE of the L spine, this is to identify the zygapophyseal joints throughout the spine. You can either do an AP or a PA projection and using a 14x17 cassette with an 85 kVp using the center cell at 40-inch SID. Your central ray will be perpendicular to your image receptor entering the patient 2 inches medial to the elevated ASIS and 1.5 inches above the iliac crest. So you're going to palpate for the ASIS, center 2.5 inches medial, and then also 1.5 inches above the iliac crest. The respiration will be suspended on expiration, again moving the diaphragms up and out of the way. For the patient position, they will be rotated 45 degrees towards away from the image receptor. And a radiolucent support should be used under the elevated side. And the joints that you're going to see are those that are closest to the image receptor. So for an RPO, you're going to see the right zygapophyseal joints, and for an LPO, you'll see the left zygapophyseal joints. Now for this Scotty dog, this is anatomy that you need to know, and while this is just a terminology used to identify what we see on the radiograph, it looks like an actual Scotty dog. The anatomy of the spine is identified here. So with this drawing, we'll go through what the drawing identifies. The ear is the superior articular process. The leg is the inferior articular process. The eye is the pedicle. The nose is the transverse process. The neck is the pars interarticularis. And we also can see the zygapophyseal joint. So looking at this here where it's circled, that is the zygapophyseal joint. We have the ear, the superior articular process, the eye, the pedicle, the nose, the transverse process, the neck, the pars interarticularis. This front leg is the inferior articular process, as well as the lamina is actually the body of our Scotty dog. So for an APO-like radiograph, we want to identify the entire lumbar with the open zygapophyseal joints and identifying the Scotty dog.